Hello, everyone. It's 7:28, so we'll just give people a few more minutes to log in. Can everybody hear me? I'm trying to unmute everybody, but it doesn't seem to be working. There we go. I think I just unmuted everybody. Can everybody see my screen? Test.
There, John?
Yeah, I'm here. Can everybody hear me or see me? See my screen?
I can see you just fine.
Yeah.
Okay. Because I see some people have their hands up, but I can't try to answer it. Just give people a couple more seconds. All right, well, I'll get started. If anybody has any difficulty hearing me or anything, just put on something in the chat or send me an email real quick, and I'll try to answer it. But otherwise, we'll get started. All right, I'm going to start the PowerPoint. All right, so basically tonight we're going to talk about what happens when you get results of an electrodiagnostic exam that you do not expect to encounter. So we'll talk about a couple of cases that didn't change the typing. A couple of cases where the testing protocol did not match the reason for the referral. We'll talk about why it's important to take a thorough history and document everything that you're encountering. A little bit review about how to interpret the results of a test and what they mean, and most importantly, discuss the clinical significance of what do we do with this information once we have it, and what does it mean. So first patient, these were both patients that I tested fairly recently. First patient was a 70-year-old male who was referred for electrodiagnostic testing a couple weeks ago by a physical therapist that's in a facility to evaluate for the presence of lumbar radiculopathy. The patient complained of a new onset of low back pain that was radiating down the right anterior thigh and right medial lower leg after having a hip replacement with an anterior approach in the beginning of this year. The symptoms for the patient began immediately following surgery. The patient had an unremarkable hospital stay, except for the new onset of pain radiating down the leg. They received home care therapy for about 2 weeks, and then started receiving outpatient physical therapy for about 3 times a week since late January. Patient was feeling and reporting that they were doing better, but they just felt that their right leg just wasn't as strong as the left, which is natural after hip replacement surgery, but he reported feeling a little bit different. His medical history from the chart review was significant for hypothyroidism, coronary artery disease, and osteoarthritis. He had a significant surgical history besides the recent hip replacement for coronary artery bypass surgery times 5 vessels, so quite significant, bilateral knee replacement, and the hip surgery in January. He was currently retired but was fairly active. Medications include Synthroid for the thyroid condition and aspirin low dose. He also reported mild numbness and tingling in his distal legs for the past 6 years. He did have a EMG and electrodiagnostic nerve conduction study in December of last year through the Veterans Affairs Committee, but he was never informed of the results. He just had the test done. They told him to come in. He had the test done, but nobody ever followed up with him with the results. So he was curious to find out what the results of this test were going to be. His clinical exam, he had diminished reflexes in the lower extremities, but they were still present. Sensation was intact in the bilateral proximal legs, even though he did report numbness in the pain in that area in the anterior thigh. It was still intact, the sensation, but as of his long-standing history of lack of sensation in the lower legs, he did have diminished sensation in the bilateral legs distal to the knee. And it was absent in the new area of sensation along the right medial lower leg. He did have a little bit of weakness of the proximal hip muscles as expected after hip replacement surgery. His knee was pretty good, knee extension, ankle dorsiflexion was a little bit weak, and everything else in the right leg was unremarkable, and left leg was normal. He did have a slight antalgic gait, but pretty good again for recent hip surgery without assistive device. He negative straight leg raise test, review of symptoms was normal, and he had no atrophy or any trophic changes. So based on that clinical exam, I went too fast. What kind of things do you think he would be presenting with? I've tried to unmute everybody, so let's see. Does anybody have any kind of guesses or ideas about what symptoms he may have, or what the electrodiagnostic test should be doing? Okay, I don't know if anybody can hear me, but basically from his symptoms, he's presenting with a new onset of either L4 or L5 radiculopathy. That was his current symptoms that he's currently presenting with. So I'm going to proceed in that manner. Yes, hello. Okay. So for his differential diagnosis, primarily I was thinking lumbar radiculopathy on the right side, primarily L4, but wanted to just double check L5 and S1. And he also had peripheral possible polyneuropathy, again, because of his distal symptoms in the distal lower legs. So for my initial electrodiagnostic plan, I was thinking bilateral peroneal motor nerve, right tibial motor, bilateral atriflex, and bilateral sural. The right superficial peroneal sensory, even though that may be indicated for his symptoms, that is not really a great test to do in this particular patient. because there is evidence that the superficial peroneal sensory nerve is often absent in patients, asymptomatic patients over 60 years old. So the superficial peroneal sensory would probably be abnormal, so it may not be advantageous to check it, but we'll see what the results are showing. Yes.
John, would you test a femoral nerve for the right side? I mean, then comparative both the side.
That could possibly be something to look at. His knee extensor strength was only 4+ out of 5, and not like worse than that.
Okay.
He didn't have any abnormal gait. He didn't have buckling. He didn't have atrophy of the leg. That would be something I would be thinking of, but that's not the first incidence, the first choice that I would go for. So it is possible, but that wasn't my first inkling.
Okay.
But that's a good thought. And also for the femoral nerve, it wouldn't really be in a case of an L4 radiculopathy, that wouldn't really be abnormal. Most of the time, nerve conduction studies, unless in severe cases, even the motor studies are normal. So the femoral nerve would not be the most ideal one to test in case of L4 radiculopathy. The EMG would be much more sensitive.
Okay.
So for EMG to look at L4, we want to check a few L4 muscles. So the VMO, the adductors, right anterior tibialis, those are very good L4 muscles. Some S1 just to kind of surround abnormality with normality and do a general screen for the gastroc and the posterior tibialis. Peroneus longus is a good L4 and L5 muscle. And then the glute medius can be done to check for another L5 and has a little bit of L4 contribution as well. And of course, obviously, with the radiculopathy, we definitely want to check the paraspinal muscles. So here is his initial results, and we can look at the waveforms, and not great, but still able. It was a reproducible sensory response. And the data, the latency was well within normal. Amplitude was on the lower side, but again, he's a little bit older, so that's acceptable. So the right sural nerve checked out pretty good. The left sural nerve, again, not the greatest waveform, but it was reproducible and evident. So again, his latency was well within normal. Amplitude was, again, a little bit on the low side, but still within normal parameters. And velocity was also normal. So the sensory nerves check out to be normal. So based on those results, it kind of lessened the likelihood of an axonal neuropathy. Again, it's possible, but the sensory nerves would be more sensitive at detecting an axonal peripheral polyneuropathy. So because of the normal sensory responses, again, I kind of moved that back on my possible conditions, and I'm leaning again more towards radiculopathy at this point. Any questions so far? Okay, so we'll go on. So here's where it starts to get a little confusing. So we look at the peroneal motor, and I did get a little bit of volume conduction at the popliteal area. The amplitude increased just slightly, but if you can take a look, the amplitudes are a little low, but again, still within normal. Velocities, latency was fine, distal latency was fine, but it's the velocities that really started to draw a flag. We saw that there was significant slowing in both the lower leg segment and a little bit worse in the upper leg, the proximal leg segment. So, and this was a symptomatic side. So, kind of, makes me take take a second step and going, what's could be the possible cause of this? The tibial motor on the symptomatic side, again, temperature was not a factor. He was very warm. Amplitudes were a little on the low side, but there was significant temporal dispersion of the proximal area, the proximal stimulation site. You see how the waveform changed shape significantly, and it was a lot smaller than the ankle site, which can be expected. You're allowed about a 50% drop in amplitude as you go more proximal in the lower extremities, but he had some significant temporal dispersion, and also the velocity was a little slow as well on the right side. So based on those findings, he had slowing of two nerves, and they were both slowing only in the proximal segments. The distal latencies on both of those were normal. I did a little bit digging deeper as far as family history, and he had no reported family history of any neuromuscular condition. So I decided to add the left tibial motor to my original plan. So I figured I wanted to go a little bit further. I didn't include the tibial motor in my initial plan, but I wanted to add to it based on the findings that I was encountering. So I continued on with the nerve conduction study, and there's the results for the left side. So the left side, again, the amplitudes were a little bit on the low side, but you can see some of those temporal changes taking place at the as we go more proximal, especially with the tibial nerve. You can see the difference in duration with the tibial motor nerve at the popliteal site. You can see the waveform is a little distorted, and the width of the waveform is a little bit wider in the tibial at the popliteal. And the data correlates with that. Again, we see significant slowing of the proximal segment. Distal segments were normal latencies. Amplitudes, again, on the lower side of normal, but still normal. And we do see that significant more than 50% drop in amplitude, or about 50% right at the border of drop in amplitude at the popliteal site, from the ankle to the popliteal for the tibial motor. Also, the late responses were even worse. The late responses were kind of symmetrical, but both were significantly prolonged. We can see the late responses. I got a little bit of a motor artifact, but I still got a reproducible H reflex response. It was reproduced. I knew it was an H because it was reproducible. The latencies were the same on both sides, so I was confident that that was an H. But you can see the slowing. He was a taller gentleman, so the latencies, and he was a little older, again 70 years old, so the normal latency was longer, but it was still prolonged for his age and his limb length. So we can see the significant slowing in both the late responses. So we now going on, taking again a second look at the data, we can see that we had bilateral H reflex slowing. We had bilateral peroneal slowing only in the proximal segments, but the amplitudes were normal. Most of the polyneuropathies tend to affect the amplitudes first and the sensories first. And as with the case, he did have hypothyroidism, which can affect the amplitudes, but that was not the case in this person. I did some more digging into his history, and as we were talking, a very nice guy, and he was a Vietnam veteran. He mentioned that, and he went to the veterans, and in using his colorful language, reported being exposed to some stuff during his service in the Vietnam War, which is very common among veterans. That brought up a tender subject. He started to get a little emotional, saying that many of his friends that are no longer with him, reporting that he had a lot of medical problems, and a lot of them had passed on that did survive the war, but a lot of them have passed on as they've gotten older. So I'm now changing my plan. I'm changing my plan because obviously all of the positive findings that I'm encountering with polyneuropathy. So I'm changing my plan. I'm going to now shift my gears towards upper extremities, towards polyneuropathy. So I did a screen while I finished setting up his lower extremities. I did a screen of the upper extremities, and the clinical exam was basically normal. Reflexes were all normal. The sensory testing was normal, and the muscle testing was, the muscle strength was also normal for the upper extremities. So there is his upper extremity results, and you can see the waveforms again. The amplitudes were a little bit on the lower side, but still within normal. As you can see, the waveform shapes were consistent. The sensory waveforms, you can just looking at the latencies, you can see that they're pretty good. But again, that late response of that F wave is still pretty far along down the path. And again, that's the protocol for upper extremity polyneuropathies is you want to do at least one motor nerve, at least one sensory nerve, and one late response. And the F wave is a little bit easier to perform in the upper extremities, so that's why I chose to go with the median nerve F wave. So the results are similar in the upper extremities as they were in the lower extremities. We see that the amplitudes were a little bit on the low side, but still normal for the motor nerves. Distal latencies were totally normal. Distal latencies were normal. Transcarpal latency was normal, but we do get that slowing of the nerve in the proximal segments. So we get slowing of the nerve in the proximal segments from the axilla to the elbow. And also the F wave was prolonged for his age and limb length, and the F wave was definitely prolonged. So summarizing the data, we looked at the upper extremity, again, had similar findings to the lower extremities. We saw that the sensory responses were normal, amplitudes were normal, distal latencies were normal, but he did have that motor slowing proximally. So based on that, we again changed my plan a little bit for my EMG plan. Originally, I was thinking just the right leg for his symptomatic side for radiculopathy, but now I changed my EMG plan. So I see I changed the plan as I went along. And what should I expect to see in this patient? Based on the nerve conduction findings, what do you think I would expect to see or to encounter in this patient? Anybody have any ideas or any questions or comments so far about what I would expect to see in the EMG exam? Okay, well, I expect to see, so far everything is pointing to demyelinating, so EMG was normal. The EMG exam was completely normal. Again, for peripheral polyneuropathies, we want to check at least 3 extremities, so that's what I did. And we wanted to check one distal muscle. So if you notice, I added the plan, I added the abductor hallucis on both sides, even though that's a painful muscle to check. I wanted to check one distal muscle because even though we don't have any, the nerve conduction data amplitudes were normal, EMG can be more specific at detecting axonal problems, especially in the distal extremities. So I did want to check a distal foot and a distal hand muscle. So I chose the abductor hallucis on both sides, but even though both sides were completely normal as far as the EMG exam. Both the bilateral lower extremities and the left upper extremity, which I checked. So the bottom line for this patient, and this was obviously an abnormal study, there was evidence of a, there was evidence of a moderate motor demyelinating peripheral polyneuropathic process affecting the lower greater than the upper. and mainly because the values were a little bit more profound in the lowers than the upper, with a proximal greater than distal and non-symmetric distribution. So it was one of the nerves on the left side was normal on the left tibial, so it was kind of non-symmetrical. There was no evidence of a focal neuropathic or radiculopathic or myopathic process. So what does that mean clinically? So a lot of times, some people think that a polyneuropathy, they're hesitant to label a patient as having a polyneuropathy because they think that there's, it's a really bad thing. Except for one instance, the polyneuropathies don't really mean that it's a death sentence. It's definitely something that should be addressed, but it doesn't mean that the patient has a few minutes to live. There's only one type of polyneuropathy that does unfortunately carry a terminal a diagnosis with it, and that's with ALS. But obviously this patient did not have the type of findings consistent with ALS. ALS, we would see normal sensory studies, and we'd also see normal motor studies or normal motor velocities, but the EMG would be profoundly abnormal with fasciculation potentials and large motor unit amplitudes and destruction of the small motor units. But every other case of polyneuropathies, it doesn't mean, so you shouldn't be afraid to classify something as a polyneuropathy. If it's got findings of multiple nerves in multiple locations, then it is a polyneuropathy. So don't be afraid to label it as such. So what do we do with this patient? Again, if you just Google it on the news, there's quite a bit of controversy regarding the medical benefits applied to Vietnam veterans. And there's a link to an article about that's from the Department of Veteran Affairs about studies that the government has done regarding peripheral neuropathy, and the findings are kind of inconclusive. But the evidence, if you ask veterans things that are not funded by the government, there's definitely a correlation with a lot of medical conditions being exposed to all the toxins that they were unfortunately exposed to. So what does this mean for physical therapy wise? Again, obviously, it doesn't mean that there's nothing that we can do. We tend to focus on, patients with orthopedic or neuromuscular injuries with, how can we improve the treatment of this patient? What can we do to help this patient's neuropathy? And, in cases of people with polyneuropathy, PT can't really fix the neuropathy. Physical therapy is not going to help a systemic demyelinating condition. This patient, we tried to refer them back to a neurologist, and I mentioned that to them to try to get their medical status managed. He was only taking Synthroid for medication and low aspirin for the heart, but he wasn't taking in anything that could hopefully slow down the demyelination process that he was having. But that doesn't mean that we can't do anything for this person. We can definitely continue with his rehab for his hip replacement, but we want to act proactively. We want to, prescribe exercises that can improve his balance, because even though it's a demyelinating neuropathy, he's going to probably develop, if left unresolved, balance issues because of the decreasing sensation that he has in his legs. Even though sensory studies were normal, we only tested the distal sensory responses. If we were to test if there were a way to accurately assess the proximal sensory conduction, perhaps maybe somatosensory evoked potentials may be helpful, maybe of some use in this case. We could maybe document some slowing there, but he definitely had clinical sensory symptoms, so we want to try to address and try to improve his overall general conditioning. by giving him exercises, doing a lot of education that can help to slow down the functional deficits that often occur with peripheral polyneuropathy. Just like physical therapy can help to a patient with COPD or heart conditions. Obviously, we're not going to fix the person's heart or fix their bronchitis or emphysema, but we can help to manage their clinical manifestations of their functional ability. So that doesn't mean that just because they have a polyneuropathy that we have to send them away. We can definitely do interventions to try to promote and restore and preserve their function. So any questions on this case? Any questions anybody has on this case as far as why the test was important, even though it didn't show the results that we were initially thinking? Anybody have any questions or comments about why this test was helpful for this patient to document the findings that he had? All right, so we'll go on. So patient number two was referred. Patient number two was referred to the practice from a spinal surgeon for an electrodiagnostic test in mid-December of last year to rule out bilateral cervical radiculopathy. This patient was a 29-year-old male who presented with neck pain radiating to the bilateral shoulders and hands, with numbness of the bilateral hands, with greater involvement of the right upper extremity, and weakness of the right extremity reported. Symptoms have been present since a fall during a work accident in May of 2016. He did already have surgery. He had surgery without an electrodiagnostic test before the surgery. He did say that his symptoms did improve slightly after neck surgery, but have recently been progressively worsening since September of 2018. So the medical chart review and history, he had past medical history diagnosed with hypertension and depression. He had no neuromuscular disorders, he had no family history, and he had no exposure to toxins. His medications, he was on significant pain medication for pain relief, for gabapentin and Vicodin, and he was also taking Wellbutrin for his depression symptoms. His surgical history, he had a ACDF, which is anterior cervical discectomy and fusion, about 1 year after the accident. And he did have an electrodiagnostic study. He had lower extremity symptoms as well. And he did have an electrodiagnostic test performed by a pain management physiatrist. And that test documented, I didn't get to review the test, but it was the report of the report was in the chart. And it did say that the impression was a severe radiculopathy affecting bilaterally multiple levels, L4, L5, S1. His imaging studies, he only had imaging studies that were available for me to review before the cervical fusion. And he did have significant disc bulging at multiple levels, worse on the lower cervical or middle cervical spine, C5, 6 herniation with thecal sac indentation, and C6, C7 herniation with thecal sac indentation. Clinical exam was mostly normal. Clinical exam was reflexes were normal, sensation was intact, and muscle testing was normal. So he had normal strength. And this patient's main complaint was pain. He had a very slow antalgic gait pattern, and he used a straight cane for ambulation. He did have positive compression tests bilaterally. So he did have positive foraminal compression tests bilaterally. Review of symptoms was mostly normal. There was no atrophy or trophic changes. Pain was his primary complaint, with reporting pain at about 9 out of 10 at all times. and he did report, even though there was no objective evidence of it, he did report severe functional limitations due to the severe amount of pain that the patient was having. So the electrodiagnostic differential diagnosis and plan, again, primarily cervical radiculopathy, likely at the C6, C7 levels, maybe a little bit of C8, not highly likely, but C6, 7 were the ones with the most positive imaging studies and symptoms of pain and slight numbness in the hands. Very unlikely, but possible carpal tunnel syndrome. He did have it worse. His right side was his dominant side. That's where more of his symptoms were. And he did have numbness in his hand, even though everything was negative, just as a possible secondary condition. So electrodiagnostic plan, kind of straightforward. Bilateral median motor, bilateral median sensory to help evaluate for the carpal tunnel syndrome. Because it is a radiculopathy, and it is likely of the C6, C7 levels, the bilateral atriflex would be helpful in this patient. At least the right ulnar motor and sensory is indicated and is more symptomatic side, but there's no, it's not incorrect to do both ulnar nerves, motor and sensory. For EMG exam, going to try to focus a little bit more on the C6, C7 muscles. So deltoid and triceps, biceps, those are all good. 5, 6, and triceps with 7. Brachioradialis is another good 5, 6 muscle. Pronator teres, I tend to like the pronator teres a little bit better than the flexor carpi radialis. It tends to be a little tiny bit less painful for patients. For the pronator teres, however, you do have to watch out for people with vascular problems. There's a lot of varicose and superficial veins in the pronator teres area, so just got to be a little bit careful. But I typically do pronator teres instead of flexor carpi radialis, but they're both the same muscle, both the same nerve root level innervation and peripheral nerve innervation. And just to complete the exam, to do the C8T1 muscles. So we'll do the first dorsal interosseous and the abductor pallicus brevis to complete the cervical radiculopathy screen. Paraspinals, again, paraspinals are part of the standard protocol for patients with radiculopathies, except in the case of surgical trauma or surgical incision to an area, because that will cause likely denervation potentials in those muscles. However, what I emphasize to mention that this patient had an anterior approach cervical discectomy. So there was no surgical incision of the paraspinals. So it is definitely indicated to perform the EMG of the cervical paraspinal muscles, because they were not cut into, even though that's where he had a fusion. You're not the EMG will not do any damage to the fusion or the fusion coming from the anterior side with the discectomy will not cause any abnormal EMG potentials. It's only of a posterior fusion or a posterior approach surgery where the paraspinals would not give more information. So the paraspinals are indicated for this patient. So the electrodiagnostic results, we can see here, the median nerve looks pretty much normal, normal looking shape on bilateral median nerves, right and left. The bilateral ulnar nerves, again, look pretty normal. The waveform size was consistent. The amplitudes were consistent. The latencies all look around normal speed. No significant dispersion or temporal dispersion or changes in the waveform morphology as we went more proximal. Sensory nerves, a little on the low side, and I'll explain a little bit why in a second. but a little bit on the lower side, but still within normal. On the bilateral median nerves, both at the wrist and the palm, no significant difference visible or discernible through the waveform analysis. And the ulnar, again, also a tiny bit on the low side, but still, reproducible and accurate responses on the sensory nerves. The late responses, again, of the H-reflex can be a little bit challenging to get an accurate study. It is one of the more challenging late responses to perform is the median nerve H-reflex. But this was a younger patient, so it was a little bit easier in general on him because he was younger. We can see that these were done with very low levels of stimulation intensity, and you can see that on the left side, we got no motor artifact, very small, no motor waveforms, and a reproducible H latency. The left side, we did pick up a little bit of noise, electrical noise on the right side. So the baseline wasn't as straight. You can see on the trace number 3 on the right side that there is a little kind of uptick in the waveform, but the one that I chose to mark the latency at was the one where the baseline was consistently leaving from. That had a consistent takeoff of that response at that location. So that's where I placed the late response latency marker for the H-reflex on the right. The EMG exam, I'm sorry, there's the results for the nerve conduction study. And again, there's the numbers, and all the numbers check out like literally right out of the textbook. So you can see there's distal latencies were all within normal. Amplitudes were normal and consistent throughout. The motor velocities were all well above normal range, and no evident decline or change from one side to the next, from one segment to the next. There's the sensory nerves. Again, the amplitudes, you can see a little bit on the low side, but I'll mention in a few seconds. The no slowing across the transcarpal segment. The wrist palm latency was 1.4 milliseconds on the left and 1.5 on the right, which is well within normal, and normal velocities across that segment as well. The left ulnar sensory, again, also normal. Normal amplitudes, normal latencies, and normal velocities. The late response H-reflex for the median nerve had no significant difference between the two sides. So there was no significant difference between the two sides. This person was also a little bit taller, but there was no significant changes from limb to limb. So EMG, as you may have guessed, is the best way to evaluate for the presence of radiculopathy. And in this case, the EMG exam was extensive. There was a lot of muscles that were tested for this patient, but basically all the muscles were normal. I did a little bit more 5-6 muscles. A little more 5-6 muscles than other areas, but again, all the muscles were normal, including the paraspinal muscles. So EMG was basically normal. Additional comments, as I mentioned, the patient did have very low tolerance to nerve conduction stimulation. I usually start with sensory nerve conduction studies first to get the patient accustomed to the experience. Even in cases where they've told me that they've had a test done before, I almost always start with the sensory nerves. And he had a severe, I want to call it overreaction to very low levels of intensity. He was violently started shaking his arms with only 15 milliamps of stimulation intensity for the sensory nerve conduction studies, so I didn't push and try to get over excessive stimulation with that. With the motor studies, I had to do a lot of convincing to get him to continue with the motor studies to get supermaximal responses for the motor nerve conduction studies. So I did have to do that. And he also, while I did the paraspinals, while there was no signs of denervation, he had a very difficult time relaxing the paraspinal muscles. Even just palpating them, they were in, before I put the needle in, they were in almost severe spasm. So we had a very difficult time relaxing the paraspinal muscles, and the motor units were, with initial needle insertion, he was, there were plenty of motor units that were firing. I had to get him into severe, extreme cervical flexion as much as you could to try to relax those paraspinal muscles and do kind of contract, relax, and relaxation techniques to try to relax those paraspinal muscles. He did do it a little bit, but it took quite a bit of time to get those paraspinal muscles to relax. So this impression, there was no electrophysiologic evidence suggestive of a neuropathic, radiculopathic, or myopathic process. When with this particular spine surgeon, I typically write that the absence of significant findings consistent with an acute axonal motor nerve compromise injury does not eliminate the possibility of nerve root compromise. The person could still have a nerve root injury that affects the sensory nerves or the myelin components of the motor nerves, which electrodiagnostic testing is not optimal for. We don't have very good, especially in the upper extremity, we don't have very good techniques of measuring the speed across a single nerve root level. So we can't really measure that latency across the nerve root level. And if it is purely a sensory nerve issue, the electrodiagnostic study is testing the injury location in radiculopathies is proximal to the dorsal root ganglion, so it's preganglionic. So because it is preganglionic, an injury to that area would not be evident on sensory nerve conduction studies. So this test, again, with this physician, he does not like to use the N-word. The N-word being normal. So just because, and I tried to educate him that just because there is this test is opposite of abnormal, does not mean that there is nothing wrong with this person. Just because the test result was normal does not mean there's no problem. Obviously, not counting any ulterior motives that a person with on workers' compensation or other secondary gains, patients could legitimately be in pain, and he definitely had severe spasm of the paraspinal muscles. So he could have a neuropathy that's only affecting the pain fibers of the nerve, and pain fibers, as we know, are too small to be detected with electrodiagnostic testing. He could also have could have developed a secondary pain-related syndrome after his initial injury, such as previously known as RSD or currently known as complex regional pain syndrome. So that could be definitely a factor in this patient. Just because the test showed no evidence of neuropathy does not mean that there's not a musculoskeletal condition going on. Musculoskeletal spasm and muscle pathology, except for myopathies, is not tested with electrodiagnostic studies. Again, evident with the physical exam, he had severe muscle spasm, which definitely can be painful. But muscle spasms, all of us have had, knows what that feels like. And muscle spasms can be incredibly painful. Again, but that doesn't mean it's an abnormal neuropathy. So he definitely could use some intervention to that area. And when I spoke to the patient about he wasn't receiving any physical therapy, There's also, and I did check the literature on this one as well, is also a significant incidence of depression and post-traumatic stress disorder after work-related accidents. There's an older study from '96 that showed that PTSD symptoms are clinically significant in work-related injuries, and a newer study from 2017 recommended looking at the psychological signs and symptoms and kind of psychosomatic disorders that result after work-related injuries. So that in this case, the patient, oftentimes patients with work-related disorders do get referred to or should get referred to psychotherapists or psychologists to address their depressive symptoms, because depression can perpetuate the painful syndromes. They could get into a pain cycle, and depression can worsen those symptoms and make them less manageable and the physical treatments of surgery or physical therapy interventions can be less effective if there's an underlying depression issue as well. So again, the point of this case was that, just because the electrode diagnostic study doesn't have any evidence of findings, that doesn't mean that there's no problem with this patient. And that's why the doctor doesn't like the word normal, because the doctor thinks that everything should be abnormal. That means that they can treat the person. But, you don't have to treat the test, you treat the person. So obviously this patient did have significant pain. And also I wanted to emphasize that there is published evidence that depression can often cause or be related to painful disorders and pain syndromes. So we want to always encompass, we think of holistic and treating the whole patient. We want to perhaps have the person assessed by psychotherapy and psychology to try to treat the underlying mental health disorders to help us with our treatment of the physical impairments as well. So those are the two cases of, kind of non-textbook presentations of symptoms and syndromes. So does anybody have any general questions or general concerns? I'll try to unmute everybody again to see if anybody has any questions. Anybody have any questions, comments, anything about the tests or anything in general?
So John, if we encounter patient like this, that they are in so much of pain or like spasm, you can see, but normal EDX, should we write any explanation in the impression, or
What I usually do is I just document like that sentence I copied exactly from the report, that just because the electrode diagnostic study was normal, or he doesn't like the N word, there's no evidence of neuropathy. That doesn't mean that there's nothing wrong with this person. That's why I document that. I can't say that there's other causes, but I say that definitely you need to correlate with clinical examination and other studies, because the electrode, even though the electrode diagnostic study was normal, he may have something that's only affecting fibers that can not be detected with electrode diagnostic study, or that to evaluate further, to use other types of evaluation methods. So that sentence, I take that and I put that on all, especially for cases where they're looking for, trying to find something. I always include that sentence, the verbatim, in my normal studies.
okay. Okay, thank you.
You're welcome.
I'm wondering how often that comes up, where you get this, it's a win if it's a normal, and yet there's a desire for abnormal only to validate something that's happening that's very real for the client.
Right.
And, in terms of some of the more central evoked potentials and some of those diagnostic testings that we haven't really learned yet,
Mhm.
would they be another option to help get some clarity, or I don't know, and maybe know more about it than me, or is it the next step is completely out of HODS?
Yeah, well, as far as somatosensory evoked potentials, if they wouldn't really add more to the picture, somatosensory evoked potentials, those are more for like central nervous system disorders like MS, spinal cord, things like that. Even if he did have some slowing of the sensory nerves or some damage of the sensory nerves, it's over such a long distance that slowing at one location, because we'll be stimulating the distal median nerve and recording off the scalp, for example, an upper extremity, and a focal slowing at only one area will kind of get averaged out over the course of the long segment. So it's there's not good evidence to show that SSEPs or evoked potentials add more to the picture with like localized neuropathy or radiculopathy.
Got it.
So that's a case where there's other things that can be addressed. Clinical skills, clinical examination, things like that. And in this person's case, there is a very high correlation with psychosocial disorders, psychological components. So we need to get the person. They were taking this patient in particular. They were given meds by their primary care, not by a psychiatrist or a psychologist. So that's something to, we want to talk about independent practitioners, but part of our role as independent practitioners is to know when to, not pass the buck, but when we need something that's beyond our expertise.
Right.
And that's definitely something that can be addressed with this patient.
Right. No, it's good.
Mm-hmm. Any other questions? Any other comments from anybody about the studies or about what my thought process was during the exam, or about the two kind of conditions in general?
John, I have a question.
Yes.
You had mentioned some possible reasons as to why maybe someone was having symptoms, but it wasn't showing up on the EMG. One of them being the pain fibers
Mm-hmm.
are too small. There was another one that you had said something about acute, like if the symptoms are too acute and it hasn't caused any nerve damage.
Yeah, if the symptoms are less than 4 weeks, then that's not enough time for Wallerian degeneration to take place of the axons. So so that's why that you need to wait at least 4 weeks after injury for any possible axonal changes to develop. And that's for the motor nerves. The clinical symptoms can definitely start right away. So clinical symptoms can definitely start, but the axonal damage that's detectable with EMG is, if it's too early, less than 4 weeks, then the EMG will not will if you cut the nerve in half. You do the test within 2 weeks after injury, and the EMG will not show any denervation potential, especially in the distal muscles, because it needs time for that cell, that Wallerian degeneration to take place, and for that cell to die off.
Okay, thank you.
No problem. All right, so if there's no other questions, thank you everybody for attending, and hopefully this was helpful a little bit, and hopefully it helps to show how EMG can be helpful, but also how we can use even a normal result to help us guide our treatment. So thanks for attending. If anybody has any questions, you can always email me afterwards. or call or text or whatever. And hopefully everybody got a little bit something out of the presentation.
Thank
you.
You're welcome.
Thank you.
You're welcome. Have a good night.
Good night.
Good night.
Good night.